So the next session is actually presented by the company Plasma Concept, and we are talking about matrix-augmented bone marrow stimulation at that point. The product we are talking about is a biomaterial made upon hyaluronic acid. As you can see here on that slide, it's available in different sizes. It's a completely resorbable scaffold, and it can be used with biological augmentation, as we demonstrate in the second video, but it can also be used as matrix-augmented bone marrow stimulation. You know that principle, combining perforation of the subchondral bone with a biomaterial in order to stabilize the clot, in order to achieve better outcome concerning the repair quality of the tissue. There was quite a bunch of biomaterials which came on the market starting in 2002. And the biomaterial which will be presented in the next video is the biomaterial HyaloFast, which is manufactured by the company Anika and distributed in Germany, Switzerland, and in Austria by the company Plasma Concept. And in the following, we will show a video that demonstrates the surgical technique of this treatment in a cartilage defect of the trochlea. The following video presents the technique of matrix-augmented bone marrow stimulation for treatment of full-thickness cartilage defects in the knee using an arthroscopic or full arthroscopic approach and using the biomaterial HyaloFast. The present case actually is a case of a cartilage defect in the trochlear groove. The adjacent cartilage is intact. There's slight reaction of the subchondral bone. The defect size is approximately 2 square centimeters. As a general remark, the positioning of the patient really depends on the defect location. For femoral tibial defects, we usually place the patient in a 90-degree position. For patellofemoral defects, in straight position. First step of the surgery is definitely the arthroscopic evaluation of the entire joint, but specifically of the cartilage defect. And as you can see here in this video sequence, this is a very proximal located cartilage defect of the trochlear groove. The adjacent cartilage is intact, and also the corresponding joint surface, the patella, seems more or less intact, which is actually a very good indication and a good situation in terms of clinical outcome. Afterwards, a second standard portal is applied, and you actually check the availability of the patient, specifically the integrity of the adjacent cartilage, using the palpation hook. First step of every type of cartilage repair afterwards is the debridement of the cartilage defect, and you can either use a sharp spoon or a curette for that purpose. The curette or the instrument also allows again to quantify the defect size, which is really important because the biomaterial afterwards has to be cut very precisely in order to make 100% fit. For the debridement itself, it's really important to create sharp edges, so do not hesitate to perform an aggressive debridement into the healthy adjacent cartilage. It's really recommended to create as perpendicular edges as somehow possible, as you can see here in the video. We do not recommend to use the shaver for the debridement. This is only used as a suction instrument, but we are afraid of induction of apoptosis in the adjacent cartilage once we use the shaver for complete debridement of the cartilage defect. What is difficult in some patients, actually in the majority of the patients, is to reach all edges of the cartilage defect perfect from only 1 or 2 portals. That's why we definitely recommend accessory portals in this technique. This is an atypical high medial portal, and establishing this portal, it's really easy to actually also reach the inferior parts of this cartilage defects. So do not hesitate to establish additional portals. This does not harm the patient significantly and makes the surgery more precise. The next step of the surgery, again, is the bone marrow stimulation. In general, we have learned that drilling of the subchondral bone should be preferred instead of using these conventional microfracturing instruments, but in the trochlear groove it's almost impossible to reach the subchondral bone perpendicular using drills. That's why we still use these instruments for the perforation of the subchondral bone in these patellar defects, as you can see here in the video. But again, be aware of not really destroying the subchondral bone. Avoid breakage in between those perforations. At that point, the defect is measured again. Again, this is important because the biomaterial needs to fit perfectly, and somehow the debridement definitely changes the defect size. And after you have estimated the size, the hyalofast implant is actually cut as precisely as possible. You can measure that also again using the curette, which has a standardized size, in order to apply this biomaterial as best as possible. For application, we actually use conventional arthroscopic instruments. The use of half pipes for establishing or for saving the portals is strongly recommended. It makes the procedure very easy, and it prevents any soft tissue interposition. Here you can see the application of the hyalofast biomaterial. Again, at this point, the third portal is really appreciated because you can actually use this third portal for the application and use the anteromedial standard portal in order to hold the biomaterial using this palpation hook. It's in general really much easier. Here you can see how the biomaterial is positioned. One nice technique is also to use the corresponding joint surface, such as demonstrated here in the video, in order to hold this. Use these half pipes in order to perfectly place the biomaterial in the cartilage defect, as demonstrated in this video sequence here. There's no additional fixation needed in our eyes, since once the biomaterial is sucked by blood, it really becomes stable in the defect. For that purpose, at that point of the surgery, you reduce the pressure and get rid of the intra-articular fluid used for the arthroscope. In some cases, it's really difficult to keep a perfect visualization, but giving this a significant number of time, it actually works in the majority of the cases, as you can see here in this video. And once you see the red out of the subchondral bone, the biomaterial becomes more sticky and actually sticks to the defect even once the joint is moved after the surgery. Concerning rehabilitation, we actually recommend limited weight bearing for a period of 6 weeks in all our cartilage repair techniques. This does not differ in this matrix augmented bone marrow stimulation setup for patellofemoral defect locations. We also recommend a limited range of motion. We recommend flexion allowed up to 30 degrees for weeks 1 and 2, up to 60 degrees for weeks 3 and 4, and up to 90 degrees up to week 5 and 6. And at that point, increased weight bearing and full range of motion is allowed to the patient, specifically for the implantation of the hyalofast product without any additional fixation. We recommend to keep the leg straight for 48 hours after the surgery. So this is more or less the standard technique. We have already heard yesterday and also today that there are some concerns about perforation of the subchondral bone, but we still need some biology for repair of these cartilage defects when using biomaterials. And this leads over to the next presentation by Gerrit Bode from Regensburg und Straubing, partner of Peter Angela, who actually introduces a special needle for bone marrow aspiration in order to combine that with biomaterials, specifically with the hyalofast product, in order to get the biology comparable to the outflow from the subchondral bone.
Dear Philipp, thanks for your kind introduction and the nice case presentation. As we all know, microfracturing suffers from rather small amounts of stem cells, even after nanofracturing. So I'd like to show you an option of how to increase cell quality and amount when performing your BMAC therapy. Bone marrow aspiration is a common surgical technique used in many sports traumatology indications. While we used to perform it with a common trocar for many years, these trocars have the disadvantage of high inflow of blood cells due to an open tip aspirating with high pressure at a very small surface. So unfortunately this is hard to avoid, but definitely unfavorable in terms of cell differentiation, which is essential for a good clinical outcome. Therefore, a special trocar has been developed which is closed at the tip, aspirates at the sides and allows you to aspirate at several levels thanks to a thread. In comparison to several trocar systems, the bone marrow solution provided by a plasma concept has proven to aspirate higher amount of differentiated mesenchymal stroma cells. We also performed a pilot study at Freiburg University Hospital comparing the bone marrow solution to a one-stage concentration of MSCs from the iliac crest using a common trocar and centrifugation in the OR. These are the results. Higher amounts of mononuclear cells for the bone marrow solution group and a smaller range of cell amount, proving the higher quality in comparison to centrifugation. Further on, FACS analysis was performed showing CD105 and 73 receptors, so we aspirated the cells we were looking for. Next question is where to get your cells from. Narbona Caceres showed that the amount of MSCs from the iliac crest is significantly higher than compared to the distal femur and the proximal tibia, where you'll rather find any stem cells. So stick to the gold standard and aspirate from the iliac crest. Coming to data, this is a nice in vivo study comparing BMAC to microfracture in a horse model, showing high amount of collagen type 2 and proteoglucane for the BMAC therapy and very good results in the post-operative MRIs. First clinical data are available as well. Comparison of 30 patients, follow-up 2.5 years, one-stage arthroscopy, once again aspiration from the iliac crest, significant increase in EKDC and post-operatively close compared to the pre-operative results. Defect sizes of up to 8 square centimeters. His results are promising, showing complete defect filling in the MRI, significant increase in the functional scores, and hyaluronic-like cartilage in the biopsies performed. recently he published his long-term results after 8 years. Still favorable results, even though the cohort size is rather small. Nonetheless, a co-sport of 94 is remarkably high in comparison to several studies examining post-operative results following cartilage therapy. In conclusion, a bone marrow aspirate can be embedded on your membrane. Special trocars increase the amount of stem cells. First results, even first long-term studies, are promising, while RCTs are still missing. Thank you.
Yeah, thank you, Gerrit, for this interesting presentation, which will be or might be a promising way in order to use bone marrow aspirates, even independent of any regulatory issues. That's still open to discussion, but definitely an interesting approach for biological augmentation, which we have already seen yesterday in the sessions, which seems to come into focus in the next year. So thank you very much to the company Plasma Concept for that partner content.